Dear Pure Urology Facebook viewers, good evening all. Today our topic is on Thulium fiber laser enucleation of prostate. Our speaker is Ketan, Vartak. I will introduce the speaker first and then I will hand over the program. So this is a video based surgical presentation on Thulium laser enucleation of prostate. Is it a new gold standard for BPH? As you all know, BPH TURP is the gold standard because hundreds, thousands and cases have compared with open prostatectomy those days. It has become gold standard. But to become a gold standard against TURP, it is very difficult. But slowly in last 5 to 10 years, if you see, lot of the youngsters are able to do the enucleation. The thulium fiber laser is has changed a little more because it's cost effective and it can be used both for the prostate and stone. Then everybody started doing and at least trying to do in large glands and getting succeeded, including myself. So to talk upon that, today our speaker is Dr. Ketan Vartak, who is working as a senior consultant urologist with Pramodini Foundation, Pune since 24 years, which has first Thulium 120 watt laser mission in Maharashtra and only second in India. Pramodini Foundation is a state-of-art urology facility with a wide variety of equipment for endourology, including flexible ureteroscope and cystoscope. He is practicing since last 1998 in Pramodini Foundation. He has done more than 25,000 urological procedures, including the modern operations like THULEF, mini-perc, ultra mini-perc, RIRS, etc. He is the pioneer of Thulium laser enucleation of prostate operation in India, demonstrated THULEF in various national workshops and has demonstrated this operation to all urologists of India. So with this introduction, thank you Dr. Ketan sir for coming here. I will just ask you few questions and then hand over. Where is your MBBS sir?
MBBS from BJ Medical College, Pune.
Oh, very good. BJ Medical College is a very well-known name. Ahmedabad also has BJ Medical College.
Yes. Because the donor was the same, Bairamji Jijibai, Parsi fellow, who was a donor for both the institutes.
Great. And who is the when did you do your MS and where?
MS also from BJ Medical, that was in 93.
Very good.
And then I joined MCH Urology in Sion Hospital, Mumbai. And MCH and DNB from Sion Hospital.
Which where? MCH?
MCH and DNB both from Sion Hospital, Bombay.
Which year?
That was 94 to 98. 97 I passed. I became a lecturer and moved out in 98. And I came back to Pune.
So, who is your mentor in enucleation?
I observed Dr. Varshnai in the beginning, but he was doing HULEP. I was beginning with THULEP. Unfortunately, there was nobody doing Thulium laser enucleation that time. But in 2008, when the 9/11 happened in Mumbai.
Now, are you doing with Thulium fiber or Thulium?
Thulium YAG laser, not Thulium fiber.
Thulium YAG.
I just wanted to correct you on that. Yeah.
So that is the thing. Thulium YAG laser you are doing.
Yes.
Okay, that's nice because in the presence of Thulium fiber laser, Thulium YAG laser has long withstood and is more easy learning. People say I have not used it. Let me also learn in this program. Thank you. Over to you, sir, please.
Thank you. Thank you.
Thulium fiber under
So first of all, thank you, Dr. Chandra, for inviting me for this pure lecture on endourology. And thank you the team Preeti Hospital and Pure team. Thank you so much. Today's topic of discussion is Thulium laser enucleation of prostate, whether it's a new gold standard. The question mark is there with a purpose because many eyebrows will be raised if I say that, if I claim that anything else is called as a new gold standard except TURP, which people believe and strongly believe that it still holds true as a gold standard. But in the next, say, 30 to 40 minutes, I'll try to convince you all that there is a new gold standard, and the gold standard will keep on changing every now and then because of the new techniques and technologies appearing every now and then. To compare TURP with various modalities, now what are the various options available in 2022? The so-called gold standard TURP is always there for us 50 years or so. Bipolar TURP is rapidly changing or displacing the monopolar TURP. Open prostatectomy, millions, or phrase prostatectomy, millions is very, very commonly done these days for more than 100 to 200 gram prostates. Enucleation by various modalities, and various modalities are available these days. Robotic transvasacal prostatectomies for very large glands, it is acceptable. And newer modalities which are in still experimental stages like aquablation, prostatolift, prostatic artery embolization, so on and so forth. Now it's interesting to know that in say 80s and 90s, why did we shift from open prostatectomies to TURPs? Because we had a belief that there was a high complication rate, high morbidity, and a very, very poor outcome associated with open prostatectomies, vis-a-vis a very, very safe and low morbidity and low complication rate associated with TURP. But then for larger prostate, everything changed back from 1990 to 2000 onwards, from say TURP to open prostatectomy, because people started admitting that TURP had a lot of complication rate like TURP syndrome, bleeding, surgery rates, long-time catheterization rates. All these things were very, very common during TURP for larger glands, and that's why we shifted back from TURP to open prostatectomy for larger glands. Now everything changed again in 2000 to 2010 era, where we are shifting back to endoscopic enucleation from open prostatectomy, and it is purely again because of the same reason that we started noticing that endoscopic enucleation can have a better outcome as compared to open prostatectomy, and the safety, the low morbidity, low complication rate, low hospitalization rate, low catheterization rate, everything was advantageous over open prostatectomy. So now people are started believing that open endoscopic enucleation can replace open surgeries almost totally. And the change, or the drastic change that happened because of the two fellows, one I admire is Peter Gilling, and second is Professor Liu of the so-called Chinese technique. Now Peter Gilling for the first time made us believe that whatever a finger could do for open prostatectomies can be easily done by a laser fiber for endoscopic enucleation, and with a much better and safer effect. Professor Liu made us believe that whatever finger could do in open prostatectomies can be easily done with a beak without using any kind of energy, and that anatomical so-called plane, nobody else believed that it was so easy to enucleate that plane with just a swing of receptoscope beak. And that was easily done, and thanks to Professor Liu and Peter Gilling for transforming TURP into endoscopic enucleations. Now, just by saying by Dr. Vartak that this is a gold standard does not suffice. The people have to believe, and for us to believe, the literature has to believe it, right? So, what does the literature say about Thulium? There are 31 publications involving 26 RCTs with more than 3,000 patients, and the comparison data was enucleation was better in terms of catheterization time, hospital stay, hemoglobin decrease, blood transfusion rates, and complication rates. Only the time taken for surgery was better in open prostatectomy vis-a-vis endoscopic enucleations. And endoscopic enucleation was at par with open surgery in recatheterization time, urinary tract inspection, urinary incontinence, and bladder neck urethral strictures and reinterventions. So in all parameters, endoscopic enucleation stands tall as compared to open prostatectomy. Whenever a new technology appears, initial results are not so good. But this is our 2012 data published in Annals of Urology that time, when only 3 years of Thulium was done in our institute. And our initial data of 236 patients suggested that in all parameters, catheterization time, drop in hemoglobin, drop in PSA, operative time, 2max, catheterization time, everywhere, as compared to data on TURP or bipolar TURP, Thulium stood tall. And so we believed that Thulium was turning out to be a very, very good modality. Now, any energy that we are using, the tissue interaction depends on the following parameters. The structure of the tissue, whether it is a very, very fibrous gland or a adenomatous gland, the wavelength of the laser, the characteristic of the wavelength of the laser is very, very important to achieve those goals. The power and energy, suppose you are using a 30 or 40 watt laser, then that obviously that energy is not going to suffice for Thulium or Holmium. Whether it's a pulse mode or a continuous wave, the so-called Holmium laser lover or Holmium lovers will always like a pulse mode, and a continuous wave like me will always love a continuous wave. Fiber size, power density, fiber properties and handling. And obviously the last is surgical technique, that is very, very important. Now, what are the different lasers that are available? Holmium and thulium lasers have stood the test of time in their reliability, safety, and efficacy. There's no doubt about that. Holmium is better in dissecting in proper planes. It's a pioneer of that technique because Peter Gilling started it, and so many years Holmium has been standing tall, and it has delivered all the results and everything. So Holmium is better in dissecting the tissue plane. Thulium is better in hemostatic properties. We'll come to the technical details later. And the versatility of different techniques. There's no other laser except thulium and to some extent thulium fiber laser, which has the versatility of different techniques that the thulium laser gives. Thulium laser is very, very fast. It can cut across all hard tissues. There are so many times the adenoma is adherent to the capsule, and we'll have to cut across the tissue planes to achieve the enucleation. So thulium laser is a very effective energy source. In case you lose the planes, you can easily cut across those tissues and correct your planes properly in thulium laser. It is very, very good in short learning curve because of the versatility of technique. You can shift from whatever technique you want to and can achieve the same goal. Thulium fiber laser, as you are quoting, is a new kid on the block and is very, very close to thulium laser in all the parameters. But the long-term results of the bladder neck contracture, strictures, the dysuria, all those things are not yet documented properly, and there are no comparative data comparing thulium fiber laser with thulium or holmium. Sooner or later it will appear, and then we will come to know. I will raise my data on the three issues: the technical issues associated with thulium, factual issues, whatever the facts say, and then the practical issues, how we go about it. As we all know that the thulium laser has a 2010 micron wavelength. So if you see this, the absorption in water as well as hemoglobin is very, very good in thulium laser. And that is the crux where the thulium laser stands tall against all other modalities, because the absorption of in water as well as hemoglobin is not so good in all other lasers. So that is the advantage of thulium laser. If you see this, the depth of penetration that we say every now and then is this. Actually, this is the laser enucleation or cutting plane. The total tissue is evaporated. The temperature appears is more than 100 degrees in this plane. Then is the carbonization effect, which is achieved by 80 degrees centigrade. Then is the 60 degrees centigrade, that is the coagulation zone. And then is the hyperthermia zone, which is 43 to 45 degrees centigrade. So the data which suggests that the depth of penetration of green light laser, thulium laser with holmium laser is this. The depth of coagulation in thulium laser is the least, that is 0.1 to 0.2 millimeter. So if you go beyond 0.2 millimeter, your tissue will be absolutely normal. So that is very, very important in the tissue reaction that it creates by thulium laser enucleation, as well as to maintain the erection and ejaculation. The green light is the weakest in all because the depth of coagulation is 1 to 2 millimeter in size. It's very, very deep and it's very, very traumatic to the tissues. The holmium laser is in between 0.3 to 0.4 millimeter. Now, the versatility of thulium laser lies in this. If you have a thulium laser of say more than 100 watt, then you have the freedom to operate in various other modalities. Like if you want a precise cutting, you stay between say 60 watt to 100 watt and you have a precise cutting. If you want pure vaporization, you can set your setting between 100 to 200 watt and you can vaporization very, very quickly. If you want to vapor resection or in between technique, then you can stay between 100 to 150 watt. So that freedom can be given by only thulium laser. This is a 200 watt thulium laser picture, but whatever I'm using is a 150 watt thulium laser these days. The advantage of newer machines over older machines is that a previous machine only one foot switch was available. So whenever I used to coagulate, I used to ask the assistant to reduce your energy from 60 watt to 30 watt and then coagulate the vessel. Newer machines have dual foot switch where cutting foot switch yellow color will be there and blue color coagulation foot switch will be there. So no assistant will be required. If you switch your foot switch from yellow to blue, you will be coagulating. So that's the additional advantage that newer machine that is given. Now, what are the advantages of continuous wave thulium versus the pulse wave holmium? It is very, very good for hemostasis. Now, there are two types of hemostasis that I call the primary hemostasis and a secondary hemostasis. You compare with incision taken from at 6 o'clock from bladder neck to verumontanum with a calling knife or a loop with a monopolar loop. Say 4 centimeter cut, you take at least 7, 8 or 10 bleeders will come across and you have to coagulate. Now, once you coagulate a bleeder, you take another cut, there will be another 4 bleeders, and all those blood vessels you have to coagulate. What does primary hemostasis mean is that whenever you are cutting with any laser energy, 90 to 95% blood vessels are taken care of at their source. I mean, they don't bleed at all. You don't see any bleeder. So that is primary hemostasis for me. Now, whenever you cut through a vessel, obviously more than 1 millimeter vessel will start bleeding. And whenever you do the hemostasis, that is what I call as a secondary hemostasis. So both primary as well as secondary hemostasis is best for the thulium laser between any available lasers these days. Whenever adenoma is adherent to the capsule, thulium can cut across and finish your job. For small glands, you have the freedom to vaporize the tissue. So if we enucleated, now we'll have to change to either receptoscope or a morcellation. So to save time, you can just vaporize the tissue within say 5 to 10 minutes. Whenever cotton balls appear at the end of morcellation, they are difficult to remove. So you can just vaporize the cotton balls or make them rough and then finish your morcellation. So in case of morcellation failure, again, you can vaporize the tissue, you can come out without wasting much time. Most important is the thulium laser technique that I use. You can avoid the stress incontinence in majority of the patients because the thulium laser has the depth of penetration is very less, and it's a very, very good cutting tool. So what I cut is not between the adenoma and the capsule. What I cut from 1 to 11 o'clock is between the adenoma and the adenoma. So a 5 to 10 millimeter of adenomatous tissue is left behind adherent to the capsule, which is adherent to the sphincter. So if you leave that area at 1 to 11 o'clock, then your stress incontinence rates are very, very less. So that technique I'll be describing later in the video. Now, what does the literature say? Again, the Thulium laser enucleation of prostate alternative to holmium. Again, this is a PubMed, Cochrane, and Google Scholar database. Right from their inception to 31st March 2020. It's a very, very recent data. Now, what does the data say? Compared to TRP and HOLEP, Thulium is non-inferior in terms of operative and functional outcomes. In fact, is associated with lesser catheterization duration as well as shorter hospital stay. So it's a very, very cost-effective procedure for BPH. That is the Cochrane data which is suggesting, and very, very, very large data. The Chinese data, again, the inference is the same, that the thulium is statistically superior to HOLEP in operation time, enucleation time, and everything, although statistically the difference is not much. Again, our own data to 36 patients, we studied 29 patients on ecosprin, 6 patients on ecosprin plus clopidogrel. The outcome was very, very positive without any complication rate. So even on patients on antiplatelets, thulium laser is very, very effective. This is Luca Carmignani, an Italian urologist who has come out with his technique of ejaculation preserving enucleation of thulium laser prostate, where he takes the incision, the inverted U incision inside 1.5 to 2 centimeter inside the verumontanum to preserve the collicular fibers, and that can maintain the function. The ejaculation is maintained in almost 2/3 of the patient. My own experience, at least 60 to 65% patients ejaculation is well maintained. Also, because of the low depth of penetration, your erectile function as well as everything else remains intact. This is our own study again, published in 2019. We studied ASA grade 3 and ASA grade 4, very, very high risk patients for thulium. 82 patients of ASA grade 3 and 27 patients of ASA grade 4 underwent thulium. And the outcome was very, very positive. None of the patients had any death, and the outcome in all the parameters was very, very positive. Now, to sum up all the things, the wavelength of 200 to 2010 is ideal for tissue absorption. Thulium laser is the most versatile laser available. It can perform enucleation as good as HOLEP. The HOLEP is so-called the pioneer or the master of enucleation. So thulium laser can compete or even superior the HOLEP technique as compared to enucleation. Now, green light laser is the master of vaporization. Enough data is available, whereas the speed of vaporization in high voltage thulium laser is far better as compared to high voltage green light laser. So even for vaporization, thulium laser is far better. So vaporization, the diode is the so-called age-old master in vaporization. Again, thulium laser stands very, very tall against the diode laser for all the parameters. Hemostatic properties among all lasers are proven to be very, very superior. Short learning curve because of the versatility of technique is also available. Now, thulium laser is very, very easy to use because it doesn't have any frequency. It's a continuous wave laser. You can always set in a pulse wave laser also for your machines, but normally thulium laser is used for continuous wave. So only the wattage needs to be set, and normally what I set is 60 watt. If you want less charging, you can set the machine as 40 watt, and many of the patients on antiplatelet are usually enucleate at 30 or 40 watts. In case you want less charging, you can continue to pulse wave mode instead of continuous wave, so that the energy dissipation will be less. If faster enucleation or more vaporization is required, you can set your setting to more than 80 to 100 watt. And hemostasis is best achieved at lower wattage. I will just run this video, short video, to just show. This is the apical lobe. It's a very large gland. I'm just sweeping with the beak, and this is how the loose technique, mechanical enucleation is done at the apical lobe. Now, this is the attachment, which is is somewhere here. Now, this attachment I can cut here, attachment I can cut here. The thulium laser gives me all the freedom to go either deep or superficial. In case I am doing a enucleation in patient on antiplatelet, I'll go superficial to save the probable or prospective venous channels or something like that. In case I want a total enucleation, I'll go much deeper. In case there are some bleeders coming in my way, I will always try to control the bleeding by staying away from those bleeders. So if there are bleeders here, I can go either superficial or deep to take care of those bleeders. You can see there's a bleeder here, I have gone superficial. So this is how the tissue planes are nicely resected by thulium laser. To go to technical details, if you move the fiber with the speed of cautery, then the charring will be less. If you stay the fiber at one place for a longer time, the charring will be more. Keep uretic orifices under vision when cutting at the bladder neck to save the uretic orifices. Thulium laser is a very, very strong energy, so always keep the tip of the fiber under vision. Try to avoid cutting into planes where blood vessels are encountered. Whenever the vision is obscured by falling lobe, you can make the space by vaporization of the tissue. You can enucleate in different planes as per requirement, as I showed you right now. The horizontal incision 0.5 cm inside the veru 11 to 1 o'clock will avoid stress urinary incontinence. Keep joining 6 and 12 gutters in curvilinear fashion. Whatever movements happen in enucleation happen in a curvilinear, this way. Nothing will happen this way. So everything is in a curvilinear fashion to have a good enucleation. And keep cutting up near the bladder neck to avoid.
Do you mean that you also use little mechanical pressure to enucleate?
Yes, especially only at the apical lobe. To see the extent of the lobe, I will lift it up mechanically and then go with. I will just show you the video later on. Yeah.
Okay.
So this is the actual technique. In 6 or 7 steps, I will describe how enucleation is actually done for the students. So this is the particular 30 to 40 gram small prostate that I have chosen purposefully because larger glands one feels disoriented. So for a smaller glands, it is easier to demonstrate the thulium laser. So this is a 30-40 gram prostate. Start with a 6 o'clock incision right from bladder neck to verumontanum. So this is hardly 3 or 4 centimeter of length. This is the verumontanum here. So take an inverted U incision just inside. You can see the collicular fibers here getting cut. So make sure that all the planes are deep enough till the capsule. If you stay superficially in one plane and deep in another plane, it will create chaos. So make sure that you are at the capsular level at all levels, because you are ultimately joining all together. So you will have to stay at one plane. Whenever stones are there, it will guide you to the capsule. But otherwise, you can stay at the capsule when your white glistening capsule is seen. Now the hemostatic properties, the primary hemostatic property is obvious. See, I am taking a sharp cut from 6 o'clock to verumontanum of almost 3.5 centimeter. Hardly any bleeders you can come across. So this is the beauty of any laser energy. All the lasers are good enough for this kind of primary hemostasis. Then this vertical incision. What is the end point of this vertical incision? Is whenever you see the trigone at the same level of bladder neck, that is your end point. Whenever you see the capsule and you can see the trigone at the same level, that is your end point. Okay, so slowly I'm splitting those fibers here. Okay, so once these fibers are cut, I will be arriving at the trigonal level. So keep cutting till the time you see the capsule, and keep cutting till the time you see the area of the trigone. So slowly, once you cut these fibers, they will come across. See, this is the uretic orifice, and you are at the trigone. So the second step is, this is a very important step that I was calling 1 to 11 o'clock incision. Now, this is you see the yellow area, that is the jarring effect of my inverted U incision. Okay, I can't see the Veru here because I'm holding my telescope with the left, the receptoscope with my left hand, which is 5 millimeter inside the verumontanum. I'm turning my receptoscope upside down, and my the fiber remains at 12 o'clock. Okay, so 5 millimeter inside the verumontanum and 2 to 3 millimeter of fiber length. So this is the length of the fiber will be protruding 2 to 3 millimeter inside. So almost 7 to 8 millimeter inside the veru, I'll be taking this cut. I will show you this cut now. Okay, the left hand holds it steady. This is the anterior commissure. Okay, so take the horizontal incision from 11 to 1 o'clock. Okay, or 1 to 11 o'clock, and keep deepening that incision till you see the capsule here. Okay, so I am not seeing the capsule at the verumontanum. I am seeing the capsule 5 to 7 mm ahead of verumontanum. So that will save my the sphincter and the stress incontinence. Then this is the anterior commissurotomy. So you extend your incision from bladder neck to, you see this incision, the length of this incision is shorter than the length of incision that I showed at 6 o'clock. Because the anterior commissure is shorter, the posterior commissure is longer. Okay. So the next step is the cleavage that is to be created. So this is the 5 o'clock or 3 o'clock incision. I'll be deepening it with little bit of gently dissecting it mechanically to see how much is the extent of the lateral lobe beyond there. Okay. Then keep on cutting and try to reach a place where you can see both 1 o'clock and 5 o'clock incisions together. Okay. So this is my 1 o'clock incision. This is my 1 o'clock incision. I will narrow it down little downward till the time I see both the incisions at one go, right? So this is from top, this is from bottom. I'll be joining only in the mucosa. Okay, only mucosa is joined here, right? Now I put my beak inside, go into this plane, and then keep on cutting.
Okay.
Okay, so your anterior commissure is shorter, posterior commissure longer. You see this. This is proximal, this is distal. The next step is to separate this lobe from the capsule. Okay, so you have made your point. This is your gutter from the top. This is the capsule on the right side. This is the capsule from the bottom side. So just keep on cutting. Everything, all the movements are in a curvilinear fashion. There is no movement which is straight because the prostatic fossa is concave. So all the movements need to be in a curvilinear fashion, in this fashion. Okay, to accommodate that prostatic fossa. Okay, now this is 1 o'clock incision. The beak acts like your assistant hand. Okay, whenever you are removing a mass, the assistant holds the mass away from you, and you will have to find a plane between the normal tissue and the mass. Similarly, the beak pushes your tissue or the lobe away, and the laser keeps on cutting. Right now, end point of this is the mucosa at the bladder neck. I am cutting it. The end point is that you should see the ureteric orifice from the lateral side. We have seen the orifice from the 6 o'clock incision. You are seeing it from the lateral side. Okay, once you cut this mucosa, you see the ureteric orifice here. Okay, so that is your end point of your lateral incision. Now, what remains is the disconnection of the lobe from the bladder neck area. So that's your next step. So again, curvilinear fashion, this is your cleavage from top, this is your cleavage from bottom. Just keep on, you don't have to see capsule because both points are known, point A to point B, which are both capsular points. So just keep on joining, and once you cut this mucosa free, your lobe will be totally free. Only the mucosa is remaining. So just cut over the mucosa, just push it, mucosa remains. Just cut the mucosa, and you will be through with your disconnection of the lateral lobe. Okay. Now you see this on the top. There is a blood vessel here. Just fire at the blood vessel, and split of a second, the blood vessel is taken care of. So this is the secondary hemostasis. Now, if you see this image, the rest of the tissue where I moved my laser fast is hardly any charring, and the blood vessel that I coagulated, I maintained my laser fiber firing for 3-4 seconds. The charring is much more. So thulium laser, if you use it like a fast moving pottery, the charring will be less. If you keep it, you stay at one point, obviously charring will be more. Now the similar thing on patient's right side. So this is the cleavage from 6 o'clock. I am cutting that cleavage and lift the lobe from the bottom. Now, for a right hand surgeon, for the patient's right lobe to get enucleated is a little difficult. So you turn your scope upside down so that your beak shifts your lobe away and you keep on cutting with the upside down position. That is very, very easy. So for this movement is difficult on the patient's right side. This movement is little easy. So always keep your scope upside down and then keep on moving like this. Now this is again the same point that I showed you on the patient's left side. Only apical lobe is remaining. This is my cleavage from the top, cleavage from the bottom. Just keep it 5 millimeter inside this capsular area, only mucosal incision, and then keep on joining these two lobes top to bottom. Okay, so this is your capsule at the veru. Just keep on cutting in between the planes so that the enucleation of the lateral lobe is achieved. Okay, so on the left, on the our left side, this is the capsule. On our right side is the adenoma. This is ventrally, or this is towards the bladder neck. This part is towards the verumontanum. You can see that this movement is so that your anterior commissure is shorter. Now, this is the technique for two lobar technique. If you are doing it for a large prostatic median lobe, whenever I see a median lobe which is broader than the single vision of the telescope, I do the three lobar technique. Now, three lobar technique, the median lobe has to be bigger. So this is a large median lobe here, which is running across. This is a cleavage on patient's left. This is a cleavage on patient's right. Okay, so you start with one of the cleavages. So keep on deepening that cleavage. Okay, so keep deepening that cleavage from bladder neck area to verumontanum. Okay, so again, the primary hemostasis is so good that whatever cut you make, there is hardly any bleeding. This is the verumontanum. So the lobe is almost overriding the verumontanum. You can see the elevation of the median lobe till the verumontanum. These are the collicular fibers that I am cutting. Patient is old, so I don't have to preserve those fibers. Okay, so till the time capsule is arrived, keep on cutting deep. This is the capsular fiber that are appearing, the white glistening fiber. Okay, now you attach this 5 o'clock incision. This is a capsule on this side. You can see the fine capsule. You attach this to your inverted U incision at the verumontanum, just inside the verumontanum. Okay, and you join the two incisions together. Okay, now little nudged with the resectoscope beak, and you will find the right plane. Okay, just nudge it, you find the right plane. You know that there is this capsular plane. You just keep on cutting. Okay. Again, the same thing you repeat on the opposite side, and now I have taken the incision on both the sides. Now I'm joining. Now there are two techniques. One is from distal to proximal technique, and one is side to side technique or corner to corner technique. Now this is the corner to corner technique where your bladder neck is under vision. You are dissecting lobe from lateral to medial side. You are not dissecting from distal to proximal. You are dissecting from lateral to medial side. So this is the corner to corner technique which is very, very safe and very easy to do. Distal to proximal. This is a distal to proximal technique. Okay. So this is your bladder neck area. I'm doing this distal. Now observe very, very carefully. My direction of these are the stones. So I am in the right plane. So direction of my laser fiber is going down. So in a split of a second, you realize what has happened. Okay. So the corner to corner technique is easier in the sense that the complication rate are less. The complication rate of going subtrigonally are higher with this kind of technique. Okay. So now retrospectively, I realized that I've gone little deep here. And in a split of a second, you will see that small perforation just inside you can see this perforation. So I've gone little deep. So what I am saying is, once you are arriving at the bladder neck, so the prostatic fossa is like this. It's a concave, right? So if you see the verumontanum and bladder neck at the same area, the rest is the concavity. So whenever you are going from verumontanum to mid point of the prostate, you go this way. If you are going from mid prostate to bladder neck, you will have to go this way, right? So if you don't go this way and you keep on going posteriorly, then this kind of perforation will keep on happening. So to avoid this, always maintain that corner to corner technique and keep the bladder neck under vision. Now, if you achieve all these steps properly, whatever size of the gland, 150, 200, 250, the maximum that I have done in my career is 250 grams. This is just 2 to 3 days back, I have done a 150 gram prostate. So at the end of enucleation, what you can achieve is this. So this is the end of enucleation. Morcellation is yet to be done. So this is the clear verumontanum. See how beyond verumontanum, almost 1.5 centimeter I have enucleated. So this is the whole fossa from this end to this end. This is the whole fossa. There is hardly any charring that you can see. This is only the charred area where hemostasis is done. This is a large lateral lobes. This is almost say 70-80 grams one lobe. You can see the extent. This is 80 grams another lobe. So total was 150 grams, and these are the fine lobes. So if you see this fossa, you can't achieve this in any of the TR or resection techniques. Only enucleation can achieve this. Now this is the verumontanum. You can see how far beyond veru is the sphincter. Okay. So for large glands, you have the safety in your hands. So whatever size of the glands, you can easily achieve this kind of enucleation. So this is again more than the 150 grams. I'm showing you 3 or 4 morcellated tissues. You can see the almost 3/4 of bottle is full. Now, whenever you are morcellating the tissue, the morcellation itself sucks the tissue in, right? So it is like गन्ने का चप्पड़ कैसे निकलता है, वो पूरा जूस निकल के बाहर आता है. So whenever you are morcellating, whatever tissue you are removing is totally without any juice left in it. So the actual tissue that you see is lesser or lesser weight as compared to the actual tissue. So you can see that how large the glands must have been. Again, this is the largest that I've done up till now. Now at the end of a 150 gram enucleation, if you see this kind of urinary color with mild irrigation, what else do you want to achieve? So that's why I'm again saying that a gold standard should be called a gold standard with all its virtues, right? So thulium laser enucleation can achieve this kind of color at the end of 150 gram enucleation. What else does a surgeon want from any of the energies? Now, this gentleman was operated in 2 sittings because he was a very, very high risk patient. So, and the gland size was 198 grams. So we enucleated in first go, and after 48 hours, we morcellated the tissue. So if you see this, we hardly see the fossa after 48 hours, right? Because we don't have to scope them again. But some scenario where you are staging your morcellation, you can see this kind of fossa. You can see this fossa here. There's hardly any tissue reaction. There's hardly any charring seen. So after 48 hours, the fossa looks so clean. So this is a pink area here. So you can see everywhere it is absolutely clean. So this is from the verumontanum. You can see hardly any apical tissue seen, hardly any charring seen. And this is the fossa, what it looks after 48 hours of enucleation. This is another very interesting case. The X-ray KUB, the sonography was showing multiple stones. The X-ray KUB itself was suggesting how large the median lobe must have been. So this is a bead of strings, multiple bladder stones. This is the median lobe. The stones were sitting in the recess, and this was a large median lobe. So in one sitting, we did the enucleation first because the stones were sitting in the recess. So I had to enucleate first and then tackle those stones with Mormel punch. So in single sitting, all the stones were cleared. This gentleman was having very, very large stones. Almost the full bladder was studded with multiple stones and with a large prostate. So I had to stage it. I did a PCCL in the first stage, and after a month, we did a thulium enucleation. Now, whenever the things are a little tricky, so this is suppose say 100-120 gram prostate. You can see the 6 to 7 centimeters of length of prostate from verumontanum to bladder neck. What has happened is, if you see this scopy finding, the median lobe is so large that I could see only the trabeculation. I cannot see the urethric orifices. Okay, so from one end to another end, if you see, you can't see the orifices. So in this scenario, if the orifices are very, very near to the bladder neck, then it is, see, the patient's right side is hardly ever possible to go into the recess. So what you do is, instead of doing 5 and 7 o'clock incision, you take a 6 o'clock incision. Dr. Varshney has pioneered this technique of bisecting the median lobe into 2 halves and do a bilobar technique. So instead of going for a 3-lobar technique, you go for a 2-lobar technique. See this? So take a 6 o'clock incision. So urethric orifice will be somewhere here. So take a 6 o'clock incision. Now we all know that the median lobe has 2 parts, like this. So it has an anterior surface, it has a posterior surface, like this, which is at the trigon. So we'll have to cut open till the posterior surface is open till the bladder neck. and then you have to visualize the ureteric orifices. So what I'm doing is I'm cutting the bladder neck from 0 to 6 o'clock. Okay. So now once you do that, I'll just fast forward it a little bit. Once you do that, you can see the trigon now. Okay. So the right orifice was somewhere here, and the left orifice, you can see it is turned a little upside. It is not here in the trigon. It is somewhere here. Okay, you can see this. This is the ureteric orifice is here. So 1 or 2 millimeter inside, I could have easily injured that ureteric orifice. Now the technique that you can use for this is that you have taken the 6 o'clock incision. Now you see the orifice, and you stay away from the orifice and take that incision here. Okay, so suppose this is almost 3 o'clock incision. So take the 3 o'clock incision and save the ureteric orifices away from your arm. Okay, so this is the incision that I'm taking at the capsule. I'm not maintaining any prostatic tissue. I'm just cutting over the capsule, but I'm saving the ureteric orifice. Okay, this is just the mucosa which is overlapping the bladder neck. Once you cut open the mucosa, so this is a bladder neck mucosa that is getting cut, little bleeding, and once you cut open, you can see how beautifully the ureteric orifice stays away, right? So this is how you can save the ureteric orifices. Now, little bit 5 minutes in case Chandra, you can allow me. I'll talk on morcellation, which is important part of.
Go ahead. No problem.
So the main problem of morcellation is the morcelloscope. Now, the vision at the end of enucleation is a problem because the morcelloscope is very, very tiny. Now, this is the picture I have taken a photograph myself. This is the morcelloscope, the standard Richard Wolf morcelloscope, which has 2 water channels. This part, which is a cavity, is for the morcellator blade to go in, and only this part is the lens. So if you compare this 4 mm telescope with a ureteroscope, 67.5 ureteroscope, the telescope of ureteroscope and telescope of morcelloscope is the same, which is almost 1 millimeter in size. So the whole problem of morcelloscope vision is because of the smaller telescope size. Okay, and that probably you cannot do away with because you have to accommodate a 14th French morcelloscope blade, right? So that only hemostasis and good technique can save.
What about nephroscope, sir? Nephroscope vision is bigger?
No, nephroscope is also the same. But unfortunately, the storm nephroscope doesn't allow the piranha to go in. So that is the problem.
Which morcelloscope you use?
This is piranha. This is Richard Wolf.
So you have separate morcelloscope, not like we use nephroscope starch and then we use starch.
Okay. The starch is 12 French, I think. The receptoscope, I mean, the morcellator blades are 12 French.
Yeah.
So now these people are also come with 12 French blades, so those we can use.
Okay.
Okay. So I'll just skip through. Now there are 2 types of morcellator. One is the shaver type of morcellator, and one is the nibbler type of morcellator. Typically, piranha and all the newer morcelloscopes are shaver type morcellator, and luminous typically is the nibbler type of morcellator. If you see the way it is done, you see the blades are rotating and there is an oscillating movement of the lobe. Lobe is moving this way. Okay, as long as you are seeing that movement, you are morcellating well. If you stop seeing that movement, you are in trouble. Vis-a-vis this, if you see, this is a nibbler. It's a to and fro movement, fast rapid movement, and it is nibbling. Okay, so that's why this is called as a piranha and this is called as a nibbler. Okay, this is the luminous blade which has a nibbling device, and this is the piranha blade. This is the teeth of the piranha, and this inner blade keeps on rotating inside this outer blade, and that will keep on taking the tissue out. Now you see this at the end of enucleation. I am seeing this vision in the morcelloscope. I am trying to fire it, but can't see anything. Now, if you keep firing at this, you are in a doom. So you never attempt a morcellation with this kind of vision. Always wait, allow the thing to settle down. In case you can hemostatize well and do the morcellation again, nothing like it. In case not, you can wait for 48 hours and do the second sitting morcellation. If you see this sitting after 48 hours, the whole lobe is necrosed completely. It becomes so soft that you can finish the morcellation within 10 minutes. And the vision is so clear, everything is absolutely fine. So whenever in doubt, always morcellate at the second stage. So I'll just skip you. So thank you so much. I have another video which is just 150 gram prostate that I showed you the end vision. I'll just run it in case anybody has any comment or queries. They are always welcome to ask.
Yeah, plate.
Yes, Chandra.
Yeah.
I'll just keep running this video. Whatever comments or whatever you want to make or queries one has to ask, you can always welcome.
I will be asking the questions.
Yeah.
Number one, if the urethra is tight,
Yeah.
what will you do?
Yeah. So tight urethra, which is not accommodating 26 French, you can attempt otis urethrotomy and do it. But I have a 22 French resortoscope as well with the laser.
Which company?
The Shoali one.
22?
Okay. 22 French receptoscope with the laser working element.
What is the size?
The 2.8 mm is the telescope, and the 22 French is the outer key.
And what about the loop? If you want to use in that loop?
Yeah, loop you can use, but you cannot morcellate because for morcellation then you have to again put a 26 French.
So if the morcellation 26 French doesn't go, if you
then you just enucleate and resect everything. Just keep the lobe at the bladder neck and keep resecting. If you make the lobe separate from the capsule.
Do you think the Foley's catheterization few days before doesn't have any sense?
But it becomes a very, very lengthy affair, and how really it helps, I don't know. And longer the catheterization time, higher is the rate of the stricture.
Stricture forms, most of these tight urethra will form strictures after
yes.
Disaster.
No, yeah, but the longer catheterization is proved to be invitation for stricture.
1 or 2 days, 1 or 2 days catheterization I am asking.
I don't think 1 or 2 days of catheterization really helps. Longer catheterization does help. But many people, what they do is put a 14th range and 16th range and 18th range. They keep on, increasing the size of the catheter for say 15 days, and then they operate. But it becomes a very, very lengthy procedure. So if your size of the prostate is not very large, you can do away with 22 French. That's not a problem. Dr. Varshney has seen his own device, which is not a continuous flow technique. It's a 20 French sheath, and there's only laser guide inside.
Yeah.
He does it with a 20 French enucleation.
Second question, whatever said and done, I am using thulium fiber laser. I have used homium. I have not used thulium laser, what you have shown.
Yeah.
If you stay a few seconds there, it chars.
Yes.
Unless you do little bit of mechanical, beautiful capsule will not be seen. If you go, okay, if it is not seen also, no problem. If you go a little bit in wrong plane also, you cannot recognize in how do you comment on that?
A little bit inside the capsule, you think?
Yeah, inside, outside, in the gland, if you go, it still looks you are going ahead.
Yeah, see this. If you see this plane here, okay, this plane looks exactly like you are in thulium laser. Whatever capsule, you see this capsular fiber here. Okay, so I don't think anything better can be seen from this, right? So this is the attachment of the capsule to the adenoma. You can easily dissect them. See these fibers. You can see the attachment here. See this here. This is the attachment towards the adenoma. I am cutting over the attachment. You don't have to see the capsule everywhere, right? You know that there is a capsule here, right? These fibers only tell you that there is a capsule here. All right. Now this whole thing I am showing you for 10 to 15 minutes. You have come across breeders only twice or thrice. This is probably the first breeder that you come across. Okay. So this I was doing it at Ruby Hall. Ruby has a 70 watt healthcare machine. It doesn't have a dual foot switch. So you have to defocus and do the hemostasis. But for quanta lasers, you have dual foot switch. So this hemostasis is far better.
If you do same thing manual enucleation, the capsule looks much better white.
Obviously, because without any energy, the capsule will be almost like a normal tissue, right? But ultimately, if you see after mechanical enucleation, how prostate bleeds. I have seen the stalwarts doing the cases, and after enucleation, pure enucleation by mechanical, they bleed heavily because many times sinuses get open because of the shearing effect. And the problem is many times because the adhesion between capsule and adenoma, if you try to lift it mechanically, it will create a perforation in the capsule because the capsule is adherent to the adenoma, and whatever you are lifting is not between the capsule and adenoma. You are lifting the capsule away from the capsule. It will create perforation.
Yeah,
So
that is true.
yeah, and bleeding
What about
because
en
yeah.
bloc enucleation? Have you done
Sorry,
en
in
bloc?
block enucleation I've done a few with for smaller gland, but I say with in case your goals are absolutely set, 6 o'clock, 12 o'clock incisions, and everything is set, then why unnecessarily be heroic and do the in block enucleation? There's no advantages over except for showing your technique. There's no advantages. It doesn't save your time. It doesn't save anything.
Hmm.
And secondly, once you take
How
the
do you
6 o'clock
decide
incision,
whether How do you decide whether two incision or three incision?
see, I see the bladder neck. In case more than 2 vision breadth of medial lobe is there, then I do a 3 lobar technique. Because then, by 6 o'clock incision, your lateral lobes are far away. Then the technique will be a little difficult. So in those scenarios, you do a 3 lobar, you enucleate the medial lobe first. Second advantage of 6 o'clock and 5 and 7 o'clock incisions is the water flow improves so much. Okay, so in block technique, the water flow is always a problem. So do a 3 lobar technique, enucleate the median lobe so that the water flow is so good. Your vision, everything so improves so well.
Hmm. And in the middle part of the gland, when you are lifting, usually capsule perforation happens.
That's what I showed you the perforation earlier.
Yeah,
See, the capsule is like this, right? This is
yeah,
the bladder neck. This is the verumontanum. The capsule is like this. All right. So once you are from the bladder, so from the verumontanum, you go this direction. Your enucleation will be perfect. But if
yeah,
you continue doing this way, you will be perforating. So whenever you are approaching from mid part of the prostate to the bladder neck, you will have to go skywards.
yeah.
Your lobe should be always lifted up, and you should always cut it like this. Never cut it like this.
So the laser tip should be at 12 o'clock position,
Not
tilting.
12 o'clock, but it should be directed towards the top. It should not be directed towards down.
Mhm.
Okay, so you see this. See this now,
I
because
will,
I'm coming from up downwards. I'm cutting it like this, but I have come here this way. I'll just show you. So this is a bladder neck mucosa I'm cutting. So I'm coming at the bladder neck area. So there's hardly any bleeding, and the tissue is absolutely. I mean, you can very well see the capsule. Now you come here. See, this hole is falling on me. So I put my receptoscope sheet down, lift the area up. This is the lobe is falling on top of me. So I lift it up, go. Now this is the plane, right? So move it upwards. I'm not going this way. I'm going this way. You see this?
yes.
This I'm going on the top. And the left hand, my receptoscope beak is holding this away. Okay, so that will create the
Have you ever tried marcellation in the lumen of the prostate?
and never tried because it's a little dangerous. Because in case the prostatic capsule gets sucked in, then it will create bleeding. So
Large prostate gland. Why don't you, after half enucleation, why don't you do marcellation?
half enucleated. But then, if in case you leave it there, it will bleed also. See, morcellation requires a large cavity, right? Prostatic fossa is a small cavity. If you have a large cavity like bladder, always morcellation is much safer and better. Because once you are in the prostatic fossa, in case the bladder is getting closer to you, you will not realize. If the bladder falls on you and it collapses, you will not even realize. So always keep at the mid parts of the bladder where the bladder is.
A lot of people use nephroscope as the marcelloscope.
Uh,
What is your comment on that? Additional instrument buying is costly. How is a marcelloscope cost almost 2 lakhs?
It does, but see what happens is normally if you keep on using the nephroscope for stone, right, for PCNL, you do thousands of PCNL. If you see the number of PCNLs and number of TORP is much higher. So if you keep using the same telescope for PCNL as well as marcelloscope, the vision is not so good unless you are changing your nephroscope every say 6 monthly or yearly. So if your vision is so good, you will have to keep your instrument only for marcellation. So a marcelloscope I don't use for anything else to keep that vision intact. Okay, so if you keep using the same instrument again and again, the vision goes, and then you will have problems in morcellation. So that's what my perception is about morcellation. This lobe is enucleated. This is the fossa. This is unedited video of one lobe.
Yeah. So
This
let
is
us,
very much.
it's already 1 hour, sir.
Yes.
So we'll stop it here. and I appreciate your enthusiasm and technical skill.
Thank
And
you, sir.
let's hope we'll listen more from you in the future, also in the pure. Thank you very much for the
Thank
nice.
you.
See,
Thank you,
at
Chandra.
the end, it is looking